All right, everyone. Thank you for coming this evening. We came to our careers night last night. Thank you very much for coming to that too. We hope you enjoyed it, and we'd love your feedback at the end. I'll post a link, and we'd love you to got some feedback because we're trying to collect what you guys need from your surgical education, what your opinions have been. We'll take that to the Department of Surgery and try and really change the way we do some education here. So tonight we are very proud to present Professor Kate Drummond, who will be presenting on neurosurgical emergencies. So please make her very welcome.
Who's heard this lecture? You got it. Okay, that's good. Most of you haven't. All right, neurosurgical emergencies. So this is obviously not about every neurosurgical emergency there is, because all of neurosurgery is an emergency. Not all, but a lot. So this is really pitched. Do you know what movie that's from? Scanners? No, yes, no. Okay. Go on with that. So it's really around at sort of medical student, intern, resident level, what neurosurgical emergencies do you actually need to know about and recognise as an emergency? And there's not that many things. You don't actually even need to know the cause of them. What you need to know is to recognise clinical syndromes that mean that you know you need to get people involved and that you need to act now. These are things that are not, you know, if you're in a GP's office, for instance, that you're not going to say, oh, here's a form for a CT scan, go down to MIA and get one in the next week or so and then come back. These are things that need to be dealt with immediately, and they're all really just clinical syndromes. So the headache of subarachnoid hemorrhage, of raised intracranial pressure and the other symptoms and signs that go with it, and spinal cord or quarter recliner compression. If you can recognise those clinical syndromes, it doesn't actually matter whether you know anything at all about the disease and what might be causing it or what needs to happen. All you need to know is this is a clinical syndrome that I need to get to a place where there's a neurosurgeon quickly. And so it makes it quite easy. So I'm just going to talk about those three things and run through them quickly, and please jump in and ask questions if you want to, and I'll probably ask you some questions. So subarachnoid hemorrhage, it's all on the history. There's all fancy tests and everything else that we can do, but it's all on the history. Sudden onset headache that the patient has not previously experienced, except in that little thing that they may have had a sentinel headache, a similar but not as severe headache a few weeks before. It's a very typical headache. The person often says, you know, I was doing nothing and I felt like I'd been kicked in the back of the head. They often feel it in the back of the head. And, you know, when you get a really good history of it, it's very easy. Often associated with reduced conscious state. And, you know, about 30% of patients are either comatose or dead. Obviously, they're the ones that you can't do much for. So it's the ones who are not comatose or dead are the ones that you don't want to miss. Associated with features of meningism, which we assume is some sort of an irritative effect of blood floating around in the CSF on the meninges. So neck stiffness, nausea, vomiting, photophobia, phonophobia, you know, the whole shebang. So that's a very easy thing to say. The trouble is that not all patients who have subarachnoid hemorrhage say exactly that, because patients are patients. So did the headache come on suddenly? Yes, suddenly. Like a thunderclap? Oh, no, you know, it was over 30 seconds, over a minute. Oh, you know, like a minute or two, or so. I mean, you've got to have a very high index of clinical suspicion. And as far as we're concerned as neurosurgeons, you know, unless you're a real idiot and you've, you know, given us a 4-hour gradual onset typical tension headache as a primary subarachnoid hemorrhage, if there's anything in the history that could even be vaguely like a subarachnoid hemorrhage, we're very happy for you to refer. That people end up in the coroner's courts about this. So very high index of suspicion, and refer, or call and ask the question, what do you think? You know, what should I do? But particularly if the patient looks sick, if they're vomiting, if they've got neck stiffness, if they're lying in bed with the wet cloth across their head, then in particular, you've got to rule out subarachnoid hemorrhage. Neurological signs, which could be due to blood, because not always the aneurysm ruptures into the subarachnoid space. It can rupture into the parenchyma and give you a hemiparesis or an aphasia if it's in the appropriate place, particularly with a frontal or temporal hematoma. It can be local pressure effects from the aneurysm on a cranial nerve, and that's particularly the third nerve palsy. And then in delayed effect, it may be related to cerebral vasospasm. So that's the CT scan. The blood is in which space in a subarachnoid hemorrhage? Yes, and what's in the subarachnoid space? So it can be difficult blood to pick. It's not a white blob. It's actually quite a hard CT scan to read. This is easy. You know, you can see this nice feathery blood coming out into the sulci and blood in the sylvian fissure over here. But in 2 days, that blood will be isodense. Very hard to pick. Or if it's only a small amount of blood, just this little bit of blood here in the interpeduncular cistern, you know, that might be all you get. So it also needs to be a good CT scan. That's why refer to expert if you're worried at all that it could be a subarachnoid hemorrhage. So, you know, there it is there, but it might look like this. An aneurysm that's ruptured, being pointing, middle cerebral artery aneurysm pointing into the temporal lobe with big intracerebral clot, subarachnoid blood. So the subarachnoid blood in this is quite subtle, just along the sylvian fissure there. And then this one's even got subdural blood, which is ruptured into the subdural space. The differential diagnosis is this stuff, but that's all diagnosis of exclusion. Okay, that's all stuff that isn't, I mean, it's sort of emergency, but it's not the same sort of emergency. So meningitis is actually a common differential, but the headache should have been of different onset, but the patient can look equally sick. Intracerebral hematoma can be a sudden onset headache, but there's usually not meningism contained, and it's more likely to have a neurological deficit. Usually there's a history, it's usually unilateral, cluster headache usually unilateral, but they can look sick, and the first migraine is often investigated as a subarachnoid hemorrhage. And then all of these other weird causes, these definitely are all diagnoses of exclusion. There's headache with exercise, there's headache with orgasm. I mean, what a bad disease is that to have, but it does definitely happen. And a bunch of other things that are in the small print in Harrison's. They only take up half of a page or something. So why is it an emergency? Maybe. That can be an, but why is it an emergency? Who cares? Space? Whatever. Yes. The reason it's an emergency is because this patient has survived their initial hemorrhage. The bleeding stopped. If they were still bleeding, they'd be dead. To rebleed. If it's a ruptured aneurysm, and the second bleed will be worse. So it's an emergency because, sure, you've got to treat the effects of the hemorrhage, you've got to exclude the cause, but the the most likely thing is that this is a ruptured cerebral aneurysm, and the risk of rebleeding is highest within the first 24, 48 hours, but continues for the first 6 weeks. And the second bleed, after you've missed the first one, so that's why it's an emergency, because this is the point of intervention that you can make a difference. So there are other causes, 70% ruptured cerebral aneurysm, that's the one you really don't want to miss. Ruptured AVM, of course that's bad, but the initial risk of rebleeding is small. To rebleed in the sort of time that you make your meandering diagnosis. We used to say about 15% unknown, although as imaging gets better, it's probably more down around 8%, and we find aneurysms with increasingly accurate imaging more and more often. And then there's sort of all the other rare stuff. Okay, so you've got your patient with your subarachnoid hemorrhage. What do you need to do? You've decided this patient's had a subarachnoid hemorrhage. What do you need? What are the management priorities?
Stabilise the patient.
Yep. How are we going to do that?
Fluids, maintain blood pressure.
What blood pressure are you going to have them have?
Probably err on the side of caution. I guess it's probably you have risk, you elevate the risk of rebleeding too low, you risk secondary damage from areas of the brain potentially not being perfused.
Yep. So what might you aim for?
100 on 90, just as a guess.
100 on 90. It's a very small pulse rate. Normotension for the patient. Okay, so if James has a subarachnoid hemorrhage, God forbid, we'd probably be going for 120 on 80. But if it's a 70-year-old man, his normal blood pressure is 165 on 140. We're not going to drop it to 120, but we don't want it above 165. So normotension for the patient. Yep, so we want to do that. What do you think the cause, so we're going to manage the blood pressure. What do you think the cause of high blood pressure might be? Why might the patient have high blood pressure that we want to control?
It's secondary to raised intracranial pressure due to the blood collecting.
Yeah, this is not a volume thing. There's not a big volume of blood. If there's a big volume of blood, they're dead. Because they've had, you've got to think this aneurysm is the carotid artery or the middle cerebral. It's not some funky little bleeds and causes a basal ganglia bleed. This is massive bleeding. So it's usually a big jet and then it has to have stopped because the patient doesn't survive ongoing bleeding. So it's usually not a volume thing. Why might their blood pressure be high?
The cause. So you're saying that there was an aneurysm to begin with, and the cause of that was the fact that they've had very high pressure in terms of it spiking.
Yeah, but that's kind of around what their normal blood pressure is. Why may they have an elevation of blood pressure?
Let's try it.
Oh, I hope it was long before the Cushing's triad at this point, but yes, someone just said it. Who said that? Exactly, they've got a terrible headache and they feel sick and they're vomiting and they're anxious and someone just whizzed them in an ambulance to somewhere or they've collapsed. So quite often what you want to do is treat their pain, treat their vomiting. All of those symptoms is an important part of initial stabilisation as well as manage their blood pressure. What are you going to give them for pain? This before, but this is the most important thing, or one of the most important things I can teach you. What are you going to give them for pain?
You go for a multimodal analgesia approach.
Okay, tell me about that, James.
So start with Panadol and then work your way
So
up.
it's Panadol. Okay, all right. How are you going to give the Panadol?
IV.
Okay, all right. As long as you're going to give, I keep forgetting about IV Panadol. It did exist when I was a girl. Okay, all right. Because it used to be the rookie mistake that the patient would come in and they'd have to go to theatre and we would have just given them all these tablets, which sort of doesn't matter, but it's also sort of not fasting, especially if they took it with a cup of tea and a biscuit. So, okay, so you're getting Panadol. That's very useful. Is that going to be is that going to be good for the worst headache of your life?
No, so you're probably looking at some IV opioids. You want to use sparingly because you don't want to alter their conscious state at the same time.
So you want good analgesia, which is opioids, and you want to have a known and titratable effect, IM or subcutaneous. That's a depot dose that in half an hour, if they go drowsy, you don't know if it's just the onset of the depot dose or not. And you want to use a drug that you know, so you know. So we use 1 milligram aliquots of IV morphine, but they're sort of the general principle. Small, frequent aliquots until pain relief, but being able to assess immediately the CNS effects.
Speaking, when you do that, do you have your registrar just by the bedside giving 1 milligram boluses until you get pain relief?
Well, luckily we've got smart nurses who do this all the time. So we put very specific instructions: 1 milligram IV every half an hour until pain relief, max 24 milligrams in 24 hours. And so that means that if the patient needs more than that, they need a scan and all of that. But I guess if you were in an ED somewhere where you didn't have someone who was used to doing that, then you'd do it yourself. But you do need to think about pain relief, blood pressure control. We've got them calm, they've stopped vomiting, their blood pressure's good, their headache's much better. What do we need to do next? Because we've done that all very quickly.
Without contrast?
CT without contrast. Interesting. Yeah, okay, yes. That would probably be what you do in most places, although we would do a CT and a CT angiogram if we really thought an aneurysm or any sort of subarachnoid hemorrhage, because that can give us 2 pieces of information on hemorrhage and where the cause is from. Management priorities are just monitor and treat the symptoms and complications of subarachnoid hemorrhage, so pain, nausea, vomiting, raise intracranial pressure, which is basically neurological observations, but that's really from a bulbing hydrocephalus, not from the volume of blood of the initial bleed. And then make sure they don't bleed again, which is basically diagnose that it's a subarachnoid hemorrhage and find out what's the cause. Largely because of this rebleeding of an aneurysm. So if you find out it's an ABM, then everyone can relax a little bit. Still got to manage the subarachnoid hemorrhage, but you've got more time. If you don't find the cause, obviously you've got nothing to treat. But if you find an aneurysm, rebleed half of the patients within 6 weeks, 25% within 2 weeks, but the actual highest risk is within the first 48 hours. And when I was training early aneurysm surgery for this reason, which means the patient would come into the ED, they would get their scan that showed a subarachnoid hemorrhage, we would do a rapid angiogram, art line, catheter, wheel them to theatre, click the aneurysm. It didn't matter what time of the day or night. I spent a lot of 3 o'clocks in the morning doing aneurysm surgery, which of course is stupid, tired. And you've got the nurse that usually does gallbladders, and she's really good at gallbladders, but hasn't done a lot of aneurysms, and she doesn't know the instruments, and it's a bad time to do it. So now we would sort of get everything sorted overnight and then do it as first case the next morning. So normal attention, straining, being urgent diagnosis, CT angiogram, or an blah, 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 and then, yeah, either surgery or clipping. How about, because you diagnosed the subarachnoid hemorrhage, you've managed it appropriately, and you've passed it on. That's what a CT angiogram looks like, with a big red arrow showing the aneurysm there, which I'm sure you can see. And if you go to a formal angiogram, posterior communicating artery aneurysm, like. And of course, we used to clip them all with a little titanium peg. Now a lot of them get filled with platinum wires that clots them off, but that's a whole other talk. Questions about subarachnoid hemorrhage? Yeah.
Just a question regarding the presentation with the headache. Is it worse at onset and then, I mean, it's still very bad, but then gets a little bit better, or is it just bad the whole time?
No, it can get a little bit better. It is explosive, thunderclap, out of the blue, light being kicked in the head, flash of lightning. They're sort of the things you're looking for. But it can be like, you know, was it? Yeah, pretty sudden. So I would reiterate that if you're at all concerned, treat it as a subarachnoid hemorrhage. It doesn't matter if you get it wrong. Really doesn't. Any other questions?
How often have you seen a rebleed occur in between the time of presentation?
Oh, often. Unfortunately, common. So 2 or 3 times a year we would have a patient bleed on transfer from another hospital. We've had patients rebleed. We had a staff member present here with subarachnoid hemorrhage who rebleed before we got them to theatre, and the second rebleed was terrible. And that was someone who everyone was running around after because it was a staff member. And we commonly see patients who present and can say, I had a headache like this 2 weeks ago, but it wasn't as bad. Super common. We certainly have patients who the registrar will be sitting up taking a history and the patient blows both pupils from the second bleed. So this is a real problem, and it's very hard for us get that sense of urgency to many people who we need to do stuff for us. And that's, you'll hear a lot of stuff about neurosurgeons. We're very bad people. We're yelling all the time, sort of shouting and running around and causing trouble. Some of that may be warranted, but you know, in these situations when you're trying to get 6 people to do a scan, get a theatre ready, get an angiogram, pressure needs to come down now, not after tea break, draw up the drug, blah, 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 blah. We can get into a bit of trouble, and this is, you know, this is the kind of problem that really sets us on edge. B. Oh no, we don't have a bed. Could they come down tomorrow? Sure. Do you think? You know, sorry.
No, you don't want to talk about it, but just briefly, what's the rate of living versus dying these days?
About 50-50. But it depends on, probably heading towards 60-40. It really depends on the aneurysm location. So almost no basilative aneurysms are clipped anymore. Morbid surgery. You know, patients were devastated by having someone poke around behind their midbrain with a closed peg. Not good. And you've got to lift up the temporal lobe, and you know, it's very terrible surgery. And so even if we can only get an inadequate coiling, if we can just get where we think the point of bleeding is, we'll do that. Middle cerebral artery aneurysms, where it's often very hard to get an angle to get a coil in, commonly go for clipping. So it's very aneurysm dependent. The nice little ones like this that we used to love doing, this was a registrar case when I was a registrar. You know, I did 20 of these in my first 2 years of training. We never see them anymore because you just put a wire up here and you drop a couple of bits of platinum in there and it's lovely. And it's good for the patient, but we miss out on a lot of nice surgeries. That's all right, we've thought of other ones to do. Okay. Intracranial pressure. Have I talked about this before to you guys? Yes? James, you probably, but I'm just working out if I'm boring people. Yes, it's all right. Okay, good. Or yes, you're bored. Okay, normal intracranial pressure, 10 to 15. Intracranial pressure when you're asleep?
Probably a bit higher since I'm lying down.
Maybe, but you're young and fit and healthy. Probably 5. What's your intracranial pressure when you're sitting up?
I think it's been around normal range still.
Might be negative. Might be negative.
Go down even more.
Yeah. What will be your intracranial pressure and you have benign prostatic hypertrophy and you're trying to pee?
Probably should do it.
What? How much?
60.
Yeah, 60, 70. Okay. So why does it matter if your intracranial pressure is raised? Like, it's pretty clear. If you all sit there now and hold your nose at strain, you'll be able to get your ICP up to 50. But most of you will not go unconscious. So clearly it's not like if you press really hard on the neurons, they'll stop working. That's clear. So what is the problem with raised intracranial pressure? Why do we worry about it?
So when the pressure can't be relieved.
No. So you mean if it's prolonged?
Yeah.
Partly. So there are a rare number of diseases which have very prolonged raised ICP that you can get visual deterioration, but that's not what I'm talking about. Why does it matter? 20, 130, 2.
So much confession there.
Kind of.
You don't want to exceed perfusion pressure?
Yes, so that's one of the reasons. So if your ICP is higher than your MAP, your mean arterial pressure, you will pass out. So that's, you heard of micturition syncope? So that's when you're 70. If you've got a MAP of 80 and you're straining against your enormous prostate to get pee out, and you get your ICP up to 80, you will fall over unconscious. So that's one reason. What's the second?
Herniation.
And why does that happen?
So raising intracranial pressure pushes the foramen magnum.
So if there's a pressure differential, two reasons are if your ICP is so high that it's higher than your mean arterial pressure, or probably your systolic, but mean you'll start to feel pretty woozy, then that's bad. Or if the pressure here is different to the pressure here, in which case stuff comes squirting out the hole there. It's very, very simple. Complicated out. So the number in one way isn't that important. You get a headache or whatever, but it's not that important. It's all about those two things. It's related to the closed box. Your skull's a closed box with a hole in the bottom. Yes. Things that are supposed to be in the box. CSF, blood in blood vessels. And if there sometimes can be something else, which can be blood out of blood vessels, pus, worms, brain tumour, other bad stuff. They're the four things that make up your intracranial pressure. And the Monroe-Kelly doctrine tells you that as the volume of any of those four things increases here, for a while the pressure will remain stable because you have compensatory mechanisms, but eventually the curve becomes steeper until with each small increment in volume, because all of your compensatory mechanisms are exhausted, the pressure will rise steeply and rapidly. And your job is to find the patient here, not here, because there's not much we can do at that point. Okay, and so that's why raised intracranial pressure, you want to identify it early, because once you get onto this part of the curve, how fast you get onto that part of the curve depends on time. So a 7 centimetre hematoma from a ruptured artery, what's the patient like? What's their clinical condition? 7 centimetre hematoma.
Pretty low GCS.
Dead. Ish. Ish. A patient with a 7 centimetre meningioma-like can be normal or very minor symptoms. Why? Hematoma happens in 3 minutes, meningioma happens in 20 years. It's all about time as well. And so a lot of the raised intracranial stuff that you're dealing with will be like glioblastoma, brain abscess, that sort of emergency stuff. And that's going to evolve over hours to days. And so you've got time to impact on that here, not here. So I think we've been through all of those things. Any of the 3 things plus the extra thing might make raised intracranial pressure. What's the headache like? Come on, round them off. You know the headache of raised intracranial pressure. Morning headache. Huh?
Diffuse.
Yep.
No.
Yep.
associated with nausea, vomiting.
Yep.
Relieved by vomiting.
Yep. Hmm?
What did you say?
Relieved by vomiting.
Thank you.
Or hyperventilating.
Yes. James knows my spiel. Why is it worse in the morning? James, tell us.
Because when you lay flat at night, your intracranial pressure will increase.
Because
Because you get increased venous or less venous return.
yes, and
Yep.
and you hypoventilate when you sleep. So, in an abnormal situation. But it doesn't happen in most normal people. Okay. No,
After you vomit, you hyperventilate.
correct. Don't believe me? Test it out next Saturday night. Spew, 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 spew. Makes your headache better. So that's quite common history. Terrible headache, they wake up, they get up, they stagger to the bathroom, throw up, feel a little bit better, gets better throughout the course of the day. But eventually, of course, the headache becomes continuous. So it's just worse in the morning. How often do patients give you that lovely classic history?
Pregnant.
Huh?
Pregnant.
What?
Sorry, I thought you said who else gives you that kind of.
No, so I said, how often do patients give you that lovely,
Never.
lovely history? Not that often, no. Pregnancy.
Throwing up, getting out of bed, throwing up in the morning.
Yeah, usually they don't have a headache. Usually that's just nausea. So be aware and suspicious for a new headache that's becoming progressively worse associated with nausea, because patients will give you all sorts of bizarre histories. And, people can have morning headache and tension headache at the end of the day at the same time. So new headache, progressively worse, especially if it's associated with nausea and vomiting. You've got to exclude raised intracranial pressure. And then, of course, eventually they're going to get drowsiness. What causes drowsiness?
Brainstem compression.
Yeah, probably downward pressure on the midbrain, because that's where your reticular activating system lives. So downward pressure on the midbrain, eventually coma, some time to develop, but in something like a glioblastoma or a chronic thing, you'll have it there. And then eventually you're on this part of the curve. Once you're drowsy, you're on that bad part of the curve, and things will happen very quickly. Will come down through the tentorium, hit both third nerves. One pupil will blow on the side of the lesion, other pupil will blow on the other side of the lesion. The neurosurgeons start doing all that stuff that get them into trouble again, because they know they've got once the pupils blow, really running into not much time left before then the brainstem, the cerebellum starts herniating out through the foramen magnum and and compresses the medulla, which gives you your Cushing's response, which gives you death. So that you want to find it when you've got headache, nausea, vomiting, papilledema, not when you've got drowsiness, blown pupils, Cushing's response, death. So I think we've actually talked about all of this. So how do we treat? How are we going to treat raised intracranial pressure? This is actually less complicated than what you would think, because all you need to know are the 4 things that cause raised intracranial pressure, and you do things that intervene on each of those things. So obviously the first thing is, if there's something extra in the head, take it out. Treat the cause. Take out the tumour, take out the abscess, whatever. That's pretty simple, but that's obviously not something that you guys will probably immediately be able to do. So then you can think about, how do I temporise by reducing the contents, the volume of the contents in the head. So you can reduce the amount of brain that's in there. It's crazy, but how can you do that?
Saline.
Yeah. What does that do?
So it's osmotically active, so
Yeah.
it takes water out of the cells.
Shrink the brain, get rid of extracellular fluid in the brain, or edema if there's edema there. What's another way you can do that? Yep. Why do we like mannitol? Why do neurosurgeons like mannitol?
It reduces creative pressure.
Yeah, but we could use hypertonic saline or Lasix for that. So why do we like mannitol?
Vascular, like it stays in the blood vessel and just to pull stuff through.
It's quick. It's good.
Yes, it's quick. Kidney circulation. Very fast. So if you're in trouble, you're old with an extradural and they've just blown their pupil and you're trying to get them to the operating room and you put a wide bore cannula in and slam in a whole bag of mannitol, pour out a bunch of pee starting very, very, very quickly because it's really quick and it's really safe. You know, like hypertonic saline, it works really well, but then you suddenly your sodium's up and this is up and that's going on and everything else, and it's all very complicated in ICU, and the ICU love it. Well, they love it. Very simple for us. We put the mannitol in, the pee comes out, and then when we don't need them to have lost that much fluid anymore, we put more fluid in and we stop the mannitol. So for an emergency situation, it's very, very fast and good. You can use Lasix, but Lasix you've got to have, you know, an enzyme reaction in the loop or something. It takes a while, doesn't it? How long does that? Lasix takes like 20 minutes to work or something. So we like mannitol because it's really fast when you're in trouble. The problem with it though, what you were saying about staying in the vasculature is that for injured blood vessels, eventually it'll start to leak out and it'll leak out into the brain and then it'll suck water into the brain. So it's kind of like an emergency management thing, which hypertonic saline doesn't do quite so much, which is why the ICU people like it and why we don't use it repeatedly or on infusion. But for a fast thing, it's really good. That's brain. Is CSF. What can you do with CSF?
Tracheostomy.
Yeah, so basically drain it. There's a lot of funky things that people used to talk about, carbonic anhydrase inhibitors to reduce its production and whatever, but none of that actually works. So even in normal ventricles, you can buy yourself a bit of time by putting a drain in. And big ventricles, obviously, you put a drain in because that's incredibly helpful, or trapped ventricles. One side, you may not drain the ventricles on the other side, so that can buy you some time. Okay, blood in blood vessels. How are we going to reduce the volume of blood in blood vessels? There's two things. Number one, blood in veins.
Right.
Yeah, so elevate the head, gravity. Valvular system, blood goes whooshing back, very effective. Come to the operating theatre when I've got a head open and we'll put the table up and down and I'll show you how much the brain swells based on the elevation of the head. I had to do a case the other day with the head down because we had an air embolus, and so the veins were actually sucking air into the heart, so we had to put the head down, and the brain swelling was extraordinary. It made it very difficult. So it's very effective, and so don't sort of think, you know, you've been to the neurosurgical ward, everyone's like this, sitting up, and it's because we know how effective it is. Okay, arteries. How do you get blood out? How do you reduce the volume of blood in the arteries?
Stabilize blood pressure.
I'm going to say now, this is nothing to do with blood pressure. How do you constrict them? Correct. Correct. So hyperventilation. How does it work?
Reduces the CO2.
Yep.
CO2 usually dilates the vessels, so
Correct.
moving that.
Yep. Capnia or hypocarbia, depending on which continent you want to live, is probably the most potent cerebral vasoconstrictor that we know. So it can also buy you time very quickly. It can buy you time quite dangerously too. Why?
Reduce the perfusion pressure.
Well, yeah, I mean, you constrict the artery so much that you've got inadequate cerebral perfusion, so you can stroke them out. Again, it's a buying time thing. So again, you've got the 7-year-old with an extradural, they've blown their pupil, they've got a young, healthy brain, they should cope. Tube with CO2 of about 25 and get them to theatre because you've got something to do and then let their CO2 come back up. You can't do that in a chronic situation in ICU, and we tend to run people at about 30 to 35, not that low, because we don't want to actually actively hurt them. Why do we sedate and paralyse people? Apart from that we need to do that to get them to hyperventilate, but why do we do that? Go away. Keep going.
So I guess there are some complications that could even increase the ICP higher, so things like seizures. As a
Yep.
response to
Seizures, what else? Correct. So they're the two things. So number one, you don't want them coughing, straining, screaming. These people have got something bad with their brain, so they're thrashing around, they're confused, so you don't want them shackled all for confused, yelling out. Best to just put them to sleep. But also seizures, other things. It reduces their intrathoracic pressure, increases venous return. But also in a tenuous, the cerebral metabolic requirements by putting people to sleep, and so you get them to use their reserve to keep as much of the brain alive as possible. And that's kind of the barbiturate kind of thing that we used to do, but which is pretty morbid. We don't do that very often anymore. So this is just the picture of the massive meningioma that the patient really had no headache at all, twitchy eye, but it can be related to the mass itself or the effects of the mass, this little metastasis that wouldn't be causing a blip except for this massive amount of edema that's around it. I think we've talked about all of those things. Any questions about raised intracranial pressure? Yes.
Why does the third nerve go first?
Where is the third nerve?
Right, it's about the midbrain.
My picture's gone.
In the brain.
In the brain. Very good. Okay. Skull is a box. There's a hole at the bottom. In the box, there are dividers. I'm sorry, am I ruining some sort of streaming there? There are dividers. There's that. What's that? There's this. What's that? Okay, excellent. There's this. What's that? Yep. There's this. Well done. There is that. What's that?
Brainstem.
Okay. The first part of cerebral herniation from whatever this explosion is that's happened there, the medial part of the temporal lobe gets pushed down past the tentorium. What runs there? Yeah. So the third nerve, along with the posterior communicating artery, third nerve palsy with the posterior communicating artery aneurysm, runs along the tentorium there as it goes past the brainstem. That herniates down and squashes it. So you blow one pupil. And then it pushes some of this under here and some of this down here. And so you blow the other pupil. You also push down on your midbrain, so you go drowsy. And part of this means you might have got a hemiparesis as well. And then it keeps coming down, and then the cerebellar tonsils do this. What's that? Medulla. Cushing's response, dead. So that's why you get the third nerve palsy, because it's right there as your herniation goes. Any other questions?
How often do you cool them down?
Cool them down. So we cool them down a lot, but actually there's no evidence that cooling works. But we cool people quite a bit because they're febrile. So patients in ICU get chest pneumonia, you know, whatever. So we know that if people have fevers, it's bad for their brain. Probably not bad for their ICP, but it's bad for their brain. So we cool them to normothermia. Cooling people to hypothermia, you know, we do it, but there's not very good evidence that it actually makes any difference whatsoever. Most of the trials are negative. Anything else? Oh, and of course, there's one other thing you can do to treat the intracranial pressure.
Craniotomy?
Sorry?
Is it craniotomy?
Yes. The other thing you can do, of course, no, I don't need that on this, is you can open the box so that the downward pressure is relieved and the pressure can be in some less damaging direction. Of course, that's a very morbid procedure as well. You know, a big frontal craniotomy like this, where your frontal lobes come shooting out, you know, across a bony ridge and venous infarct and everything else. And in fact, the biggest trials of craniectomy have shown that that produces bad quality survivors in trauma. So it does increase survival, but it produces bad quality survival. The trials in stroke are somewhat more promising that it can be useful. So we still do some, but less than we used to, because the big multi-centre trials show that we produce bad survivors.
And at what point do you sort of make that call, say in a country hospital, where
that should not be done in a country hospital.
Okay. So it's better to try and get them here than to say drill the hole or something.
Oh, no. Then.
That's I meant drill the hole.
Okay, so the rules would be that if a patient has, okay, it's quite complicated. In trauma, if the patient has a drainable lesion and you either can't get them to a hospital within 4 hours, you think they have a drainable lesion and you don't even have a CT scan, and you can't get to a CT scanner within 4 hours, they say that the most competent person there should either drill burr holes or do a craniotomy. That in practice is a very nice idea, but the places that really need it, Tennant Creek, have no one there with even any surgical skills, and so that's just ridiculous. But it does occasionally happen from Wang or places like that where they have very competent general surgeons who've done the appropriate course, and they have a CT scanner and they know that the patient has an extradural or a subdural and they're deteriorating rapidly, and that they know that the transfer will take more than 4 hours, and so they will do that. It's a really, really, really big call. And really, I don't think anyone should make that in isolation. That should be on the phone to a neurosurgeon. And that's what the guys in Wang do. They call us up. What do you think? What should I do? Send us a picture of the scan. Go ahead. And they often come down just with the scalp flapped over for us to finish the craniotomy after the initial pressure has been relieved. But I wouldn't recommend you do burr holes. Trouble is, a person who's not used to doing burr holes will probably take 4 hours to do the craniotomy, like just to get through the first bit. So they probably could have got to Melbourne. Okay, very quickly, because I can't say that, I'm sorry. Spinal cord and corticotonic compression. I'm not going to go through this too much, except that there are 4,000 causes of this. Many of them. You really, really, really don't. You just need to know how to recognise the syndrome, and if it's rapidly progressive, know that it's a neurosurgical emergency. And this, might think this is not common, but we frequently, every year, have people who have a cervical epidural abscess, large thoracic in a vertebral body, who come to us in a very delayed and irretrievable fashion because they've been missed. And the people who do are particularly the people who don't complain of too much pain, the little old ladies, the non-English speaking, the immunosuppressed, people that we don't like looking after, like the drug addicts and the nasty people, and for one reason or another, their symptoms are either ignored or not even seen, like the little old lady, no one checks her legs for 2 days and then suddenly thinks, oh goodness, she hasn't been out of bed for a little while. So they're the patients that we see all the time, once every 2 months. So understanding this constellation of symptoms, it's a neurosurgical emergency. If it happens acutely, you've got 48 hours and then it's a permanent deficit. That's it. No more, not going to get better. And if it's sort of over a few weeks evolving, you're unlikely to get back what happened 2 weeks ago, but you might get back some of the stuff that happened recently. So it's really important. Pathology is either extradural, pressing onto the theca. That's 80%. And they're the patients with infections, metastases, trauma, degenerative disease. Intramedullary, they're the patients with tumours. They have quite a specific presentation, sorry. And intramedullary, rare, but usually fairly obvious, 5%. They're the causes, see, 8,000. By the time you put all the different pathological diagnoses and all the different infective agents, 8,000 causes, doesn't matter. Just recognise the clinical syndromes, which are extradural compression by metastatic tumour, abscess or degenerative spinal disease, which in the cervical cord will give you a specific syndrome, in the thoracic cord will give you a specific syndrome, will give you a specific syndrome. Those tumours, intradural, extramedullary, and then a tumour in the spinal cord. So I'm just gonna, you don't need to, I'm gonna go through this bit. So what's the presentation that you have to not miss? Pain and neurological deficit. That's it. It's very easy. Except for one thing. What's not easy about it?
You have to do a good neuro exam.
Yeah. It's usually a pretty sort of, you might not be able to describe it well, but it's usually a pretty slam dunk kind of neurological deficit. You know, leg not moving, incontinence. Yeah, you're right. But what's really hard? Everybody's got pain. Half of what comes into the ED is neck, back, or pain, leg pain, arm, sore neck. So it's actually, you know, the problem is that people miss it because, you know, lots of people have pain, and working out which of the people who have the appropriate pain or the significant pain is the difficult thing. But you reckon they get in overnight with back pain in our ED? Could be that, but it's at least 10 every night. You know, that they have to make a decision. How many of those people will say, I've got tingling or numbness or I can't walk? 8. How many of them in urinary retention? Every single person who's in Sunshine Hospital that they want to get out of there because they don't want to have a neurosurgeon and they're annoying them. So they get urinary retention because they get given narcotics and they're constipated and they're lying down and they can't pee. So, you know, again, it's the same thing as a headache of subarachnoid hemorrhage or raised intracranial pressure. high index of clinical suspicion. And actually, we don't mind. When Sunshine calls us up and says, we've got a person with back pain and, you know, it's new onset back pain, it's very bad, and they've never had it before, and now they've gone into urinary retention. And by the time they get down to us, you know, they've had 50 years of back pain, 27 work cover claims, and they've just been given 400 milligrams of morphine, and if we got them upright, they then could then pee. We don't mind, because actually it's important to recognise it. But that's the real difficulty, because everyone has pain. Obviously, the pain depends on the side of compression, set of compression, and on the neurological deficit, whether the nerve roots are involved. So is it just spinal cord compression, or will there be radicular pain? The cause, so inflammatory pain like abscess or whatever, tends to kind of be worse than a slowly growing tumour, but not necessarily. And whether the blood supply of the spinal cord is involved, because if it is, the patient may just go off. No, let's not put that there. What's red flag pain?
Night pain.
Night pain. Yep, history of cancer.
Under 20 or over.
Yep, God, I'm a red flag.
Not really for medication.
No, I haven't heard that one, no. Yeah, drug user, fever,
Association with trauma.
yes,
History of steroid use.
immunosuppression, which can be drug use, steroid use, AIDS, cancer. Diabetes is one that people often miss, the little old lady with diabetes and long-standing urinary tract infections. That sounds about right. So the pain usually comes first before the neurological deficit, but depending on the cause, obviously, if the pain really happens when they have a vertebral collapse, you know, they're going to get immediate pain and neurological deficit. Due to involvement of pain-sensitive structures, all of those things, diffuse dull burning, sciatica in the lower limbs, brachialgia in the upper limbs, and girdle pain, which is often missed. So gallbladder, all sorts of other reasons, but girdle pain from the throat, or part of, you know, pulmonary embolus, all of those things when it's radicular pain in the chest. Progressive weakness. So obviously, if it's of the cord, it's a spastic upper motor neuron weakness. Okay, without wasting. And the weakness is often not prominent to start with. The spasticity is prominent. So the stiffness, the increased tone, and whatever. And often, you know, they can still they still can push you away, do all of that kind of stuff. But the spasticity is often early. You know all about upper motor neuron lesions. Cervical cord, you might have a lower motor neuron lesion at the level that the roots are involved. That's pretty subtle. That's down to your good neurological examination. But we'll don't mind if you don't get that, as long as you don't miss the upgoing toe and the clonus. That's okay. Disturbance, of course, is a hallmark finding, and that's how you work out where you're going to look. Although the sensory disturbance is often a couple of levels below the lesion, but that's where you're going to work out where you're going to look. There's the sort of spot diagnosis stuff, Brown-Séquard syndrome, from a hemicord section, very uncommon. I've seen very few in my life, and usually from tumours, that thing with the tumour growing on the dura on one side. I did see a man who tried to stab himself in the head with a samurai sword. He tried to stab himself in the back of the head with a samurai sword. That's what the demons told him to do, and of course he slipped straight down his occiput and cut one half of his cord in half, and gave himself the perfect Brown-Séquard. But that's the only really perfect one I've ever seen. The cape-like loss of pain and sensation, pain and temperature associated with a lesion in the middle of the cord, expanding it. That's for advanced. Okay, you don't really need to know that. And saddle anesthesia, you all know about that. So do the PR, check the saddle sensation if you're worried about a patient having quarter-equinal lesion. But don't ask me to explain the sphincter disturbance. I don't understand either the parasympathetic or the sympathetic innervation of the bladder. I don't know really. I'm going the wrong way here. Where's the, yeah, I don't know. I don't understand it. Sometimes they can't eat. Sometimes it's dribbling out. I don't get it. But if it's doing one of either of those things, it's bad. That's all I can tell you. Okay, questions? I have to learn it. I do the neurosurgery exams every single exam. There are 2 things I have to go and look up again for the questions. The innervation of the bladder and the brachial plexus. True. I can't remember those things. I can't remember them. Now I'll say to them, okay, can you draw me the brachial plexus? Oh, that's good. I think I have it tattooed somewhere so that I can answer. Any questions on spinal cord compression? So that's all you need to do. Recognise those 3 things, and at your level, the entirety of neurosurgical emergencies. Okay, good.